Thank you very much, Dr. Rui. I appreciate having such a wonderful opportunity. Japan is known for its unique culture and heritage preserved since ancient times. I hope you all have the opportunity to visit Japan and enjoy traditional Japanese food and beautiful places such as Kyoto. My own family name, Hattori, is the same as famous ninja warriors. Ninja warriors were active in feudal Japan and used special martial art techniques, such as making themselves invisible, to gather intelligence. Unfortunately, I cannot use these ninja arts. Today I am going to talk about the lessons I learned from my failures. Now deceased Professor Brannemark much worried about problems of peri-implantitis in the last years of his life. He said that he had exhausted implant success stories and recommended us to learn from treatment failures. Endodontic treatment is no exception. The success rate of endodontic treatment is said to be around 70 to 80%, but we will have more to learn from treatment failures than from successes. We are now experiencing amazing advancements in endodontic equipment such as operating microscopes, cone beam CT, and nickel titanium files. However, it should be noted that these new technologies cannot provide maximum benefits without careful examination, diagnosis, and treatment firmly based on fundamentals. Before I present my cases, I'd like to apologize to my patients who experience complications or unfavorable treatment outcomes, either unavoidable or caused by my own errors. Now, I'd like to share my failure experiences with a wish that I will never repeat the same mistakes again. Endodontic treatment failure often involves various factors. Today, I am focusing on 3 topics: perforation, differential diagnosis between endodontic and periodontal diseases and associated complications, and risks from endosurgeries. Now let's see access preparations. The tooth on the right shows severe calcification due to aging and has old fillings for treatment of root surface caries. When this kind of tooth needs access preparation, the risk of perforation is very high. I'd like to talk also about the prognosis of this kind of case and the technique to prevent perforation. Please remember this tooth because treatment outcome of this case will be presented at the end of this topic. Risks associated with access preparation include gouging of tooth wall in the cervical area as shown on the left, and the perforation as shown on the right. The case on the right side is my error. 7 years ago, I made a perforation accidentally at the floor of pulp chamber. I repaired it with MTA, and the outcome was good. The reason was that I confused mesio-buccal canal with mesiolingual canal. Moreover, I made access preparation on lingual aspect. I had no experience of any mistake like this for a long time. However, I made a mistake a few months ago which resulted in an infrabony perforation of the second premolar. I immediately repaired it with MTA, but the risk of root fracture remains unavoidable. The cause was mesial inclination of the clamp. The prognosis of perforation is affected by 5 factors listed here. Perforation is repaired either by non-surgical or surgical procedure. When surgical repair is selected, the position of perforation is critical. Communication with oral cavity via periodontal pocket will have significant influence on infection or contamination. A perforation at a deep area, as shown on the right, is repaired by conventional procedures, assuming that it is a new canal. Let's see some actual cases and compare treatment outcomes. This canine had a large perforation due to a metal post. There was swelling of attached gingiva, but there was no communication with periodontal pocket. I repaired the perforation by injecting super EVA cement from the canal and restored the tooth after confirming improvement of the symptoms. 5 years later, the patient showed recurrence of gingival swelling. I selected surgical treatment, elevated the flap, and repaired using super EVA cement again. Today, after 10 years from the treatment, there is a sign of slight cement resorption. During maintenance care, I will check carefully for fracture of thin cervical area and communication with periodontal pocket, which may cause infection by periodontal diseases. This is a patient referred to me. No communication was detected by probing, but the lesion extending to the furcation seemed to be reaching the apical lesion. There was a large amount of granulation tissue inside the canal. I removed the granulation tissue with electric scalpel, treated with calcium hydrate, and filled both the lesion and the canal with MTA. 4 months later, recurrence of swelling was found. Re-examination by cone beam CT revealed significant extension of the lesion all over the mesial root. Thus, the root was extracted. I carefully examined the extracted tooth and found that the filling inside the oval lesion was not tight enough. Today, MTA bioceramic is the best material for perforation repair. In areas with external communication, however, MTA has a risk of disintegration, and the use of Gerrestore is recommended. However, how about fast-set MTA? I thought it could be used for lesion communication with periodontal pocket. I will show you the result of treatment by fast-set MTA. In the case of this patient, the apical lesion arising from lateral branch was communicating with bone resorption due to fracture. After explanation of all treatment options and risks, the patient desired to preserve the tooth. Therefore, I treated with Angelus, which sets in 15 minutes, and Endosim, which sets in only 4 minutes. This is an X-ray examination 8 months later. Periapical radiolucency disappeared, but there is a deep pocket at the center on the labial aspect. MTA partially came off and showed black discoloration. The apical area is covered with bone. However, the endosim in fracture area remained uncured, disintegrated, even in a very deep area. Is this a problem of the product? If I had used Angelus, could I have avoided such a problem? Is MTA contraindicated in areas communicating with oral cavity? I will discuss this later in the section of endosurgery. To prevent access perforation, preparation should be made toward the largest canal, not toward the chamber. We should not try to show the entire area, but try to identify the canal you find first. Then, using that canal as a reference, identify the anatomical structure of the dental pulp and search for other canals. For some cases, I do not use high magnification until I find the chamber so that I can maintain good visibility of the coronal profile and neighboring teeth. As Dr. Castellucci taught me, I do not use a turbine for access preparation, but use the Strat X ultrasonic tips. The cutting efficiency is higher than I expected. Most important is the good visibility thanks to the Start X ultrasonic tips. I can see, which makes me feel safe and comfortable during surgery. I can feel cutting performance with my fingers. I am surprised by the sense of safety and security that the device provides me. What is the key to patient-centered treatment success? As a recent trend for long-term preservation of natural tooth, more emphasis is placed on preservation of structural component in the cervical area than on the success rate of endodontic treatment. Today, conservative treatments are recommended to prevent root fracture. Preservation of cervical dentin layer is of great importance for the longevity of treated teeth. For this reason, recent trend is toward less straight line access. However, less straight line access is very skill sensitive and requires in-depth anatomical knowledge and careful examination, for example by cone beam CT, and correct diagnosis. Any complications due to ledge or file fracture will prevent you from attaining the original purpose of treating endodontic problems. The purpose of straight line access is to avoid encroaching upon the furcal danger zone, prevent excessive load on files, and avoid troubles such as fracture on ledge. The great master told me the importance of feeling the canal, and for this he keeps the file away from anything in the upper area of root canal. This tooth number 7 has a strip perforation at the furcation due to my mistake. I did not notice the perforation at all until I checked the CT scan for implant treatment. I repaired the perforation with BC Patty. Now, as my summary of access preparation, I'd like to show you a video of the treatment of tooth number 7, the first case in this presentation. I hope you remember the tooth with significant calcification. My treatment approach includes preventive care, preparation of enamel using a turbine, and then searching for palatal canal using START X number 3. Once the shape is identified, I change the instrument to number 1. The instrument number 1 is thick efficiency, with no groove at the tip. I use ProTaper Universal S1 and S2 to gain good orifice visibility, and number 10 to create a path to the apex and establish patency using an M4 contraangle. Once enlarged to ProTaper Next X1, I use SAF for simultaneous and continuous instrumentation and irrigation. I was impressed by the lecture of Dr. Oscar von Sturten on SAF at the Endomaster 2015, and fortunately, I had the opportunity to learn from him. I love SAF. I love SAF. This is the only file that can enlarge and irrigate root canals simultaneously. This case presented fusion of the two buccal roots. Therefore, I used ultrasonic irrigation as a precautionary measure. For filling of tooth number 6, I used single point technique of BC sealer and bioceramic points, and for tooth number 7, CWCT technique using GP and AH+. Tooth number 6 was non-vital, had root infection, and was comparatively round-shaped with severe calcification. Therefore, I selected the single point technique in expectation of bioactive effect of the sealer and prevention of excessive pressure. On the other hand, tooth number 7 was a fused vital tooth with oval shape on the buccal aspect. This is why I use CWCT technique that allows heating and pressurizing. Now I'd like to talk about the second topic, differential diagnosis between endodontic and periodontal diseases and associated complications. We have to determine whether the problem is of endodontic origin or periodontal origin, or both. Let's see some clinical cases. This patient has a localized deep pocket on the mesiopalatal aspect of the right upper molar, and it seems to be reaching the periapical radiolucency. The cone beam CT shows radiolucency around a mesiopalatal root canal, which I could not detect. This suggested to me that the problem was of endodontic origin. The cone beam CT 3 years after the endodontic treatment showed that the lesion had healed, which proved that the problem was of endodontic origin. If endodontic origin is suspected, it is the fundamental rule to provide endodontic treatment first. Wait for at least 15 days after the endodontic treatment and then start periodontal re-examination. Lesions of periodontic origin often have wide and shallow pockets. There is no possibility of endodontic origin if the tooth has vital pulp. Now, how about this case? Radiolucency was found only around tooth number 7 in the lower right quadrant. The patient was in his late 30s and had repetitive swelling at MGJ for more than 1 year. There was secondary caries. The periodontal pocket did not disappear after endodontic treatment. Note that this tooth was vital. Root fracture is quite frequent among the cases where endodontic or periodontal problem is suspected. 4 to 13% of failures of endodontic treatment are due to root fractures. This patient had no clear caries pit of tooth number 6 in the mandible, but the pulp was extubated due to spontaneous pain. The patient said the pain persisted for some days after the treatment. A few years later, swelling occurred and a large radiolucency was found around the distal root. It was a root fracture. The tooth number 7 in the left upper quadrant had vital pulp. About 1 year later, localized deep pocket was found on the distal aspect. This was also a root fracture. When did these root fractures occur? Did they occur before treatment? Did I miss root fracture during initial examination and make the wrong diagnosis? As we know, when caries occur on the adjacent surfaces, cracks of enamel are found in most of the cases. Did the pit occur from the crack? When and by what factor was the fracture induced? Was it induced during treatment? Big tapered file, straight line access, pressure by CWCT, after treatment, post and occlusal coverage, poor bonding. There are so many factors to be made clear. I have no clear answer about endodontic and periodontal origin. However, it seems to me that the key is pulp vitality test, an examination of the entire jaw for periodontal disease. Lastly, I'd like to talk about endosurgery. Endosurgery is the last hope for preservation of tooth and is very important. In surgical treatments, rapid healing is observed in the post-operative first year and 85% healing after 3 years. However, the rate of problem recurrence over time is high. Thus, long-term follow-up after healing is a must. The treatment of this case was through and through, therefore healing with scar formation is observed. No bone graft material was used. This case was treated by an oral surgeon. The surgery consisted of cyst removal and apectomy after decompression therapy. We can see healing with scar formation. What are the reasons that surgical treatments are contraindicated? There is no doubt in the contraindications listed on this slide. This patient had pain of right upper tooth number 6 after retreatment at my clinic. There was a lesion at the palatal root, and I was having a hard time in choosing surgical treatment or tooth extraction. However, this patient did not visit us for 5 years since then. When the patient came back, lesion was enlarged and sinus floor bone resorption was found. I am referring this patient to a university hospital. How about this case? We can see advanced palatal bone resorption. It will be very difficult to remove the lesion using labial approach. The bone supporting the tooth will also be lost in this approach. My colleague, who is an experienced oral surgeon, warned me that root fracture is frequent in such a tooth. For TNT cases and those with severe bone resorption extending to the cervical area, treatment combined with GTR will be recommended. This patient exhibited bone resorption in the cervical area, but there was no attachment loss due to periodontal disease. I already mentioned endodontic and periodontal factors. This case was of endodontic origin, and the marginal bone will regenerate once the apical lesion is properly treated. I have never combined GTR with endodontic surgery. What I showed you is everything I did for the treatment. I used no GTR membrane or bone substitutes. I do not think many of you will choose to preserve this tooth by providing surgical treatment. This patient, however, did desire the preservation of the tooth. Even if we cannot expect a long-term good prognosis, I thought surgical treatment is worthy enough if it can promote bone regeneration for future treatments. I used Angelus MTA for filling. 3 years later, the bone resorption in the periapical area was filled with regenerated new bone. I repositioned the mucosal flap towards cervical area, but recession occurred. Should I have used graft material or membrane to prevent the recession? Resorption of MTA is observed in the area communicating with oral cavity. The patient had no problem. However, I removed them during re-entry. Please see the video. I elevated the flap to refill the MTA resorbed area at the central incisor. As you see, the bone resorption at the periapical lesion has been repaired, but the cervical exposure remains unchanged. The MTA resorption and pore hardening are observed only in the area above the gingival margin. I repaired again by changing the material from MTA to Super EBA. This patient visited us with a complaint of persistent swelling after endodontic treatment of left and right central incisors at another clinic. All these 3 teeth showed sinus tract, and at the left central incisor, excessive gutta percha is extruding from the apex. We can notice a significant gutta percha contamination. The excessive gutta percha could not be removed and remained outside the apex. The sinus tract did not disappear, and I filled the canal with ProRoot MTA. When I removed the temporary coverage at the second visit, the MTA I used at the left upper central incisor did not harden and was contaminated. Communication with oral cavity via sinus tract was considered to be the cause of the hardening failure. I cleared the lesion again and filled with Angelus. Angelus hardened with no problem, maybe due to the product characteristic of fast set. At a later date, the excessive gutta percha was cuttered away using surgical approach. Then, the sinus tract disappeared. We are now at the stage of prosthetic rehabilitation. In areas communicating with oral cavity, even fast-set material may result in poor hardening. I have shown the cases of apicoectomy. Now I'd like to show you one case of transplantation. This patient visited us with an acute problem of very bad pain of tooth number 7 in the right upper quadrant. She could not sleep the whole night due to the pain and visited me. No caries pit was found. The pain disappeared after infiltration anesthesia. I extirpated the pulp and no problem occurred after that. At the follow-up recall after 3 years, there was a 9 mm deep pocket at the center of buccal aspect. The patient had no spontaneous symptom at all. The cone beam CT scan revealed radiolucency in the periapical area as well as in the maxillary sinus. Therefore, I consulted with an ENT doctor. I suspected periapical lesion or root fracture. I extracted the tooth with a plan to transplant it if possible. However, transplant was impossible due to the calculus accumulation extending from the furcation all the way to the apex. From the clinical symptom of this patient at the first visit, I should have checked ascending pulpitis or root fracture because he had pulp inflammation without caries. Due to my insufficient examination of periodontal disease, the tooth was lost in only 3 years. So my conclusion is nothing special. Importance of careful examination and diagnosis applies also to surgical treatments. Now I will show you a case from which I had renewed sense of the importance of examination and diagnosis. I found an enlarged radiolucency around right upper tooth number 4 after endodontic retreatment and prosthetic rehabilitation. Please note how the Please note how the overfilling looks different between X-ray and actual images. This raises a question to me as to the resorption. The fact might be just a reduction of radiolucency, which may look like absorption to us. Endosurgery is a reliable and effective treatment modality. However, disease recurrence rate of 5 to 40% has been reported, which indicates the importance of a long-term follow-up. The importance of examination and diagnosis applies to any treatment. In particular, diagnosis of fracture is very difficult, and there are cases we cannot find fracture until surgery. When new technologies such as cone beam CT, OMS, and nickel titanium files were becoming available, I felt as if I could achieve more successful treatment outcomes. In reality, however, the cone beam CT reveals radiolucency around many T-cell-provided endodontic treatment. What does true healing mean? I am torn between hope and despair by the results of cone beam CT scanning. Treatment. Last but not least, I'd like to refer to the statement of one of my dearest friends, Dr. David E. Jaramillo. Yes, we can provide full benefits of various advanced technologies to our patients, if and only if we have good diagnostic abilities. Before closing my presentation, I'd like to thank all MSC members for their kind assistance and guidance. Thank you very much for your kind attention. Feedback from you will be very much appreciated.